Emphysema by Michael Day. We're going to discuss emphysema. It affects 4.7 million Americans and affects 20.2 persons per 1,000. And over 90% of our emphysema cases were individuals over the age of 45 years. So this is something respiratory therapy deals with quite a lot. So we're going to dive in deeper and discuss emphysema. Emphysema. Emphysema is a long-term progressive obstructive lung disease in which the alveoli, the small air sacs that promote oxygen exchange between the air and the bloodstream, are destroyed. This causes increased shortness of breath and loss of elasticity in the alveolar walls that have not been destroyed. Emphysema is quite common in the United States, as a lot of people still smoke. It affects 20.2 people out of every 1,000 persons, and over 90% of emphysema cases are individuals over the age of 45. Over the past 5 years, the amount of women contracting emphysema has increased by 63% compared to 6% decrease by men. Women have now surpassed men. There are 21.4 women with emphysema out of every 1,000 compared to 19 men out of every 1,000. So that's 2.5 million women and 2.1 million men with emphysema. Emphysema was first reported by Dr. Watson in 1764. He had a 28-year-old patient with shortness of breath and a productive cough, and when they died, he did an autopsy and he observed greatly distended lungs, large bladders filled with air in which no pressure on the lung could force back, and ruptured blebs filled with bloody fluid. In 2011, in the United States, 4.7 million Americans reported having emphysema. Emphysema is primarily caused by smoking. Other factors, such as occupational exposures, lifelong of inhaling like paint fumes, asbestos, and different things like that, different dusts and whatnot, airborne pollutants. These also can cause emphysema. And alpha-1 antitrypsin deficiency is another major cause of emphysema. Smoking. This is the single most preventable risk factor for causing emphysema. Smoking accounts for 90% of emphysema cases in the United States. Bottom line is if we get people to stop smoking, emphysema will reduce greatly. While smoking is the major cause of emphysema at 90%, the other 10% is alpha-1 antitrypsin deficiency, or AATD. It's the most common genetic factor for developing emphysema. It's a protease inhibitor, and deficiency of this causes the release of elastase by migrating neutrophils, causing damage to elastin and to the development of emphysema. It affects individuals who are homozygous for the ZZ mutation. People that have this mutation oftentimes have the most severe COPD. They can develop emphysema without ever having touched a cigarette. But in particular, if you smoke and you have this ZZ mutation, you have the most severe COPD. So some of our most severe cases of emphysema are smokers, plus they have alpha-1 antitrypsin deficiency, or AATD. Common symptoms of emphysema: being barrel-chested, being short of breath, persistent cough, oftentimes a congested cough producing phlegm. Person that has difficulty with activities of daily living. What we mean by that is going to the bathroom, they get short of breath, can't make it to the mailbox and back without stopping, Something I've seen a lot is people have difficulty tying their shoes when they bend over. Uh, they're pushing their diaphragm up, reducing their lung volume, and have a hard time with doing things like that. Um, we see cyanosis also, usually not central cyanosis of the lips. That's the very end stage. Uh, but in stable, severe COPD, you'll see cyanosis of the fingertips, or acrocyanosis. Looks like somebody's been reading the newspaper. Fingers are a little bit dusky, look like they have ink on them from reading the newspaper. Diagnostic testing for emphysema. We use pulmonary function testing is one of the main reasons or main ways that we diagnose COPD, but then we use other methods also, like CAT scan of the lungs, the alpha-1 antitrypsin deficiency screening. You can use ventilation perfusion SPECT, and simple resting and ambulating oxygen saturations. The more of these different types of testing that you can put together, that paints the more complete picture for diagnosing emphysema. But most importantly, in my eyes, the smoking history or the person's lifelong history. Getting a great history and physical gives us the best indication if they're likely to have some sort of emphysema, as they're above the age of 45 and short of breath, and they exhibit some of those barrel-chested signs and having trouble with activities of daily living, that kind of thing. The treatments of emphysema. We use a lot of breathing treatments, a lot of inhaled medications. The primary one is a short-acting beta agonist, otherwise known as SABAs. That's your albuterol type medication. Then we use long-acting beta agonists, or LABAs. That's like Serovent or formoterol. We use anticholinergics. These relax the muscle basically by blocking acetylcholine. We'll get into that further, but that's your Atrovent, ipratropium, Spiriva, tiotropium. We use inhaled and systemic steroids for the treatment. And then another option is lung reduction surgery. This is basically where they can go in and get rid of some of the dead space by lasering out some blebs. And then long-term, pulmonary rehab has been shown to give patients a lot more stamina, help with the activities of daily living. It doesn't do anything per se for the lungs, but it does help the heart and lungs, and the patient become more conditioned so that they can do things better. It also puts them around people in the same situation, other emphysema patients, so that they can get kind of a support network and kind of push each other to work harder so that they can improve their lives as much as possible. Now, these magical beta-2 agonists, how do they work? Well, when a beta-2 agonist attaches to the receptor, cyclic adenosine monophosphate is produced, which relaxes and opens the smooth muscle cells in the walls of the airway. What this does is it increases the quantity of air and oxygen reaching the alveoli and pulmonary blood capillaries. If a patient is wheezing, what that does is it relaxes and opens the airway, creates a larger lumen and large bronchi, gets rid of some of that wheezing, and creates a better flow of air and oxygen out into the lungs, reducing shortness of breath as well. The SABAs, or short-acting beta agonists. This is our first line defense against emphysema, first line treatment. We have at our disposal levalbuterol, that's your Xopenex variety, albuterol sulfate, which is under many trade names, salbutamol, and terbutaline. Pretty much the standard is to give albuterol unless they have cardiac implications where a very high heart rate of 120, let's say, then they tend to give the Zopanex or levobuterol. LABAs, or long-acting beta-2 agonists. Some of the LABAs we are familiar with are like salmeterol, which is Ceravant. Some of the newer ones are formoterol, which is Floridil, or arformoterol, which is Brovana. Brovana is a breathing treatment form of these. The other two are only available in inhaler, like dry powder inhaler, DPIs. But what they can do is help prolong, give you 12 hours. It's used twice a day. Give you 12-hour coverage for inhaled beta agonist, but you still have to use your short-acting. Muscarinic antagonists, otherwise known as anticholinergics. This is like your Spiriva, your tiotropium. That's the newest generation. That's a long-acting, once-daily dry powder inhaler for the management of emphysema. Most common for most of us that have been doing this quite a long time is ipratropium bromide or Atrovent. That's a short-acting variety. It often comes where you can mix it with the albuterol sulfate, and in my eyes make the drug much more effective and make it last a bit longer as well. How these drugs work is they block acetylcholine or cholinergic receptors in the bronchial smooth muscle and inhibit bronchoconstriction. Steroids. Steroids are used in the most severe group of COPD patients with repeated exacerbations and the more severe airflow limitations. It's often used in a crisis. If someone's in the emergency room, they need several or a couple of back-to-back breathing treatments, and they still kind of fail to improve. That's usually when they hit them with some steroids. Usually the systemic variety is what they're using. Older generation, we give Decadron. Now they have Solumedrol and Prednisone. Solumedrol is an IV form. And Prednisone, they can put them on a Medrol dose pack and let them taper off at home alone after they get out of the hospital. For chronic management, inhaled steroids are available. That's your budesonide or Pulmicort, your fluticasone or Flovent, and mometasone. That's also available. Some of these drugs come in combinations as well. You can get the Symbicort, which is a budesonide formoterol combination, Advair, which is a fluticasone Ceravant combination. Next, some of these severe emphysema patients are candidates for lung volume reduction surgery. It has been shown to reduce lung hyperinflation. Again, they kind of go down and laser out some of the blebs and help reduce some of that severe air trapping. It helps improve the spirometry and breathlessness of the patient. Usually improves the exercise performance and improves the quality of life. For chronic stable management of emphysema, a lot of pulmonologists recommend pulmonary rehabilitation. Promotes regular exercise, kind of supervised exercise. They can increase or decrease oxygen so that the patient can kind of push themselves to get on a treadmill or a bike and increase their endurance. And what this has been shown to do is reduce dyspnea, reduces their anxiety, increases their self-efficacy, and improves their health-related quality of life. Like I said, they also get a good support group because they meet like-minded patients with the same symptoms. They can get tips and feedback. They can also encourage each other. Usually helps out quite a bit with the overall outlook for a patient. Prognosis of a patient with emphysema. This can vary wildly. The life expectancy, it's near impossible to find any real hard data because it depends on so many different factors, on when they're diagnosed, what comorbidities exist, if they have extreme heart problems or congestive heart failure, things like that. Despite emphysema being progressive disease, people have been known to live 20 years with proper care and lifestyle choices. If they stop smoking after they're diagnosed, just a lot of it just depends on what stage. Emphysema stage 1 through 4, 4 being the most severe or end stage. It depends on when they're diagnosed and how severe it is as to whether or not you start counting how many years they can live with it. But generally speaking, I've seen plenty of patients in stage 4 emphysema that pretty much can live, in the 5 to 10 year range with proper care. Emphysema prevention. Emphysema prevention is pretty much boils down to one thing and one thing only, and that's stop smoking. That's the number one culprit. You can get screened for the alpha antitrypsin deficiency. That itself can give you emphysema without smoking, but that is a very small percentage of people. Stopping smoking is the single most important thing worldwide people can do to stop emphysema. Not only that, we need to develop programs, smoking cessation programs, that really key in and teach our younger people never to start smoking. That's the key to the entire thing, is getting that next generation that knows the hazards and have seen their parents and grandparents die of emphysema. Help them never to start. They're not. They believe they're invincible. They think life is so long. And as we get older, we find out life's pretty short, pretty precious, and we need to do everything we can to maintain our health. Emphysema carries many social and mental effects. A lot of people suffer depression and anxiety. There's a lot of guilt with a lot of people because they feel like they brought it on themselves by smoking, which is true for the vast majority. The increased shortness of breath usually keeps them confined to the home, so they have less socialization. That is a bad thing, to be a whole person, not to be able to get out and socialize as you once did. And same thing with this is you have difficulty traveling. Traveling just becomes a chore if you have oxygen and nebulizers and inhalers to carry with you, especially if, in those golden years you want to take that trip to Florida or that cruise, that trip of a lifetime. It's very difficult to fly, or take a cruise if you're on oxygen. You have to make arrangements well ahead of time, possibly go rent some different types of equipment that Medicare or Medicaid does not cover, so maybe cash money out of pocket. It becomes pretty expensive. And then having portables, you have to find, say, a company in Florida that maybe will meet you at the airport or is not far from the airport, so you can go get some portable cylinders as a backup to a concentrator or whatnot, short-term rental kind of thing. How does emphysema affect the ability to deliver care from a respiratory therapy standpoint? Well, number one, it's a very complex disease to manage in an exacerbation with impending respiratory failure. Generally speaking, most emphysema patients that are not in the hospital are stable. Many continue to smoke, so they don't require a lot. But when they come into our emergency departments and our ICUs and they're an impending respiratory failure, that's a whole another animal that becomes fairly difficult to manage. Juggling various things: blood gas analysis, oxygen therapy, bronchodilator therapy, mucus clearance. Then we get into non-invasive ventilation to keep them off mechanical ventilation. The goal is not to intubate these people because they become very difficult to get off the ventilator. Although as technology increases and caring gets better and better each and every year, we get a substantial number of emphysema patients off the ventilator that are intubated. Not as many get hooked like we used to think 20 years ago. And then for all those who have that severe emphysema, it eventually does kill them. So then we move into palliative care, So you've got a patient in impending respiratory failure. It's kind of at the end of the rope. That's when we need to give them assistance with palliative care, and then eventually that leads into a hospice type scenario. Again, thank you for listening. The references are posted here where all the information was gathered. Hope we learned a little bit about emphysema, its treatments, its causes, its prevention, and we can all take that back to where we work and help people live a better life and keep people away from cigarettes. Thank you very much.